extension of the trabecular may more significant. To avoid the secondary collapse of the superficial scleral flap over the trabeculodecime membrane, metomycin C and many types of implants were placed in the intrascleral bed like Hyaloflu, Esquegel, Olagene, Collagen, hyaluronic acid. The new stopper Eclipse is a non-reabsorbable implant, which objective is to maximize all aqueous humor drainage pathway. There is two shapes, but I use the one with 2 feet, 2 plates at the upper right corner. In the surgical technique, first in deep sclerectomy, we do the superficial scleral flap, 1/3 of the scleral tips, reaching to 2 millimeters in the clear cornea, then the deep one dissected and then removed after doing the peeling off the inner wall of the Schlemm canal or the external wall of the trabecular to obtain a good filtrations. Then we will put the implant, one plate, we put it in placed in full thickness suprachoroidal bag, 2 millimeters behind the sclera spore. The other plate, put it in the scleral leak without suturing because there is 2 lateral notches in this implant that fixes the implant and preventing from the anterior displacement. We achieve to intrascleral PLIP by create intrascleral bucket from the posterior limit of the intrascleral plate fixed to the posterior edge of this implant, thereby helping to keep the scleral lips apart. This is the PLIP the day after the surgery. It's high PLIP. And prospectively, there is a significant correlation between the height of the PLIP and the decreasing of the IOP. Anterior segment optical tomography scans were done through the sectal and the transversal plans to the implant, as you see, and the average of the initial IOP for the 6 patients follow up to years, 31.8, and the final IOP 12.1, and the present reduction of the medication used in 93. And all the patients had a primary open-angle glaucoma and controlled glaucoma despite being on maximal medical therapy, and were all of them over 18 years old. Anterior segment OCT showing the transscleral and the suprachoroidal, and the high PLIP, it consists of intrascleral PLIP, subconjunctival PLIP, and UV scleral outflow. Sorry, I want to conclude. To conclude, non-penetrating with a snopper Eclipse implantation suggests an effective and well-tolerated method to reduce IOP and seems safe implant with promising results. Further prospective studies are needed, and this implant acts as space maintainer and lead to the aqueous hemorrhage drainage to suprachoroidal, suprascleral, intraconjunctival space, as suggested by this non-invasive imaging technique that lead to morphological analysis of the drainage mechanism. Thank you.
I have a question, Dr. Noha. Dr. Noha? Yes, I have a question. Do you get hypertensive phase with this S-Noper implant after deep sclerectomy?
I don't hear.
Do you get a hypertensive phase after this implant? A few weeks down the line after the surgery, do you see a rise in pressure or a change in the architecture of the conjunctiva?
Only you mean by visual field? What do you mean? I don't understand the question.
Actually, it depends what do you mean by the question. Do you mean a hypertensive phase similar to what you get with a valve or a tube, or? No, you don't. But you get, typically after an S-Noper clip, pressure in between 2 to 5 in the first week, and then it starts to go up, and if you are lucky, it stabilizes by the 6th week around 12 to 15, something like that. And in any case, if the pressure goes up, you can always puncture those clips, and it works very well.
So you don't need to use any additional 5-fluorouracil as you would use any?
I use mitomycin for those cases intraoperatively always. And if I have to needle, which is not extremely common, I would also needle with mitomycin. I'm not a big user of 5-FU.
Thank you.
Thank you.
So our next speaker is Dr. Omnia Hammam, and she would be talking about her experience with iWatch. And we would like you to join us after you're done with your talk.
Hi, good evening. So my talk today will be about the iWatch surgery. Yeah, I have to wait. Dr. Amari, he asked me to talk about my experience with the iWatch. So actually, until they put my presentation, I enjoyed a lot doing the iWatch. It's a new toy, I think, for the glaucoma surgeon. Anyone had an experience with the iWatch implant here? We consider the UAE as the 7th country worldwide to implant the iWatch, and we have 4 surgeons did it in UAE. Yes, thank you. I have no financial interest with this device. Okay, so the iWatch, it's a watch, it's an implant, world first adjustable glaucoma device drainage, and it's made by Rayon Medical Switzerland company in Swiss. First implant done by Professor André Mermoud in Lausanne on the 15th of September 2015. And this device has CE approval, but no FDA approval yet, until now. The system, it consists of 2 devices, implant and the iWatch. It's an implant and the plate itself, coming with a magnetic pen. This plate is a non-valve plate, and the system actually consists of iWatch flow-resistant device connected with the plates and magnetic disc, which control the open and close this tube inside. It's coming with a magnetic pen. The magnetic pen has a compass and has a magnetic from the other side where you can open and close the iWatch and control the flow. I think there's videos. So this is the watch here. The watch, it's formed by PEK material. The tube inside, silicone tube. And we have the nozzle, this is the unique about it. The nozzle, it's rigid part of the tube itself and the anterior chamber. I think there's a video, we missed it. The eye plate, two sides of the eye plate, 200 and 300. This is the plate, and what we are using now is the 200. Here there's small comparison between the iWatch and the other devices. What's unique about it, that the plate, it's a little bit longer than the other plates, and the width is smaller. The tube, the lumen itself, it's exactly like the Pervelt tube, so we can use the iWatch device itself with Pervelt as well, or with the iWatch. Yeah, this is one of my surgery. This is the last surgery I did. We open the conjunctiva, like we prepare the conjunctiva deeply, like any glaucoma device. So we go deeply, because this is a long plate, so we need to create a good space. And we used to put it 12 millimeter, or we have to put it actually 12 millimeter from the limbus, because you have to keep good space for the watch itself. It's two devices together. I used to take the muscles. I used to take the muscles actually with all the glaucoma drainage devices, and I think I advise to take it with the iWatch as well. I sutured this plate here with the 8-0 nylon. Actually, I tried different types of sutures. Last time I did it with the nylon 8-0. I'm looking always for a spatulated needle, so it will be easy to do a good track in the sclera posteriorly. There's 7 millimeter between the two holes, so you have to take good demarking. It's very flexible and soft material of the plate. The plate itself is silicone and it's thin, so friendly, by the way. And then we take like a stamp. The stamp, it's taking the design of the watch itself. So here I'm taking the design of the watch itself, and then we do our flap, our scleral flap. I think this is the step which is most of my colleagues, when they come to see me, they don't like it. Even myself, I wasn't accepted when I was seeing our senior colleagues doing it. We feel like this is a step which is a little bit extra, and we don't use to do it with the other glaucoma drainage devices. But you have to do it. It has to be a little bit deep, so you can put your